Bismillahirrahmanirrahim. Assalamu alaikum everyone and welcome to this symposium which is by Sante, Revolution in Ophthalmology Symposium. Um we have basically four speakers. Uh, One by one we will have their introductions. We'll change a little bit sequence because the presenters have little clashes with the other presentations. The first speaker for the presentation is Professor Mohammad Muin. He is head of ophthalmology department at Mayo Hospital, Lahore. He is also pro vice chancellor at King Edward Medical University and CEO, College of Ophthalmology and Allied Visual Sciences. His presentation talk is on the topic of the impact of Nipephenec, 0.3%. Does it really make a difference?
Assalamu alaikum, Saeed, and it's a pleasure to be here today at the Lahore Ophthalmo, the 43rd Lahore Ophthalmo. And thank you all of us for joining us in this meeting and make it a great success. The topic today, I think it's NEPAC Fort, which we are talking about. It's a non-steroidal anti-inflammatory drug. And the important thing is comes in a higher dose concentration. And the number of times you have to put the drug in, the compliance is better because the number of times you have to put in is less in these patients. Usually these type of sort of presentations can become slightly, because you know all the things about it anyway, but I'll try to incorporate things which just to refresh your memories, and probably we can have an interaction at the end before we finish off so that we can sort of make it more interesting for you. So the anatomy, as you can see, when you put a non-steroidal anti-inflammatory on the eye, and the current use of non-steroidal standard anti-inflammatory and pain relief, and you can see when you get surgical trauma, especially in patients with cataract surgery, you're going to induce a uveitis, and then phospholipids are secreted, and then arachidonic acid is secreted, and you've got the COX pathway in which you have cyclooxygenase inhibitors by NSAID. So it blocks this part of the inflammation. So the main aim is to reduce the inflammation. So what is the advantage of using this rather than using an anti-inflammatory, which would be a topical steroid? Why not just use steroid compared to patients just use adding up non-steroidal anti-inflammatory? Because there's a discussion that you can either use NSAID or you can use steroids, or do you want to use a combination? So we'll see which one works out better for us in long term. So the post-surgical inflammation, we've already decided. So this is the arachidonic sort of arcade, and there's inflammation being produced, and the cytokines growth inhibitor factors are sort of released, and they are stopped because of this. The NEPAC is a so it's a prodrug. It is going to go through the cornea and is going to get converted into amphetamine. So in order to make it a once a day formulation, because everybody knows that the NEPAC or Nepafenec is a very viscous solution, and you need to shake it before you put it in the eye. And the problem was why you want to come into a once OD sort of preparation. I think when you give NEPAC or any drug having Nepafenec, you will see that because of the viscosity, sometime after cataract surgery, especially in dry season, you get crusting of those sort of particles on the lashes. So it's important to sort of shake the bottle before, and once you put the drop in, and you need to wipe it off as well. So if you have less amount of that drug in the eye, that is going to help the patient get the thing. So we've already said, so it comes in a 4 ml bottle and one drop beginning 1 day prior to surgery. So why do you want to sort of use it 1 day before surgery rather than on the day of surgery? So one thing is non-steroidal anti-inflammatory medications are useful for keeping the pupil dilated during surgery, and it blocks the pain before you actually start the inducing the inflammation. I can give you an example. I was treating somebody for PRP, and I've been doing that for a long time, but never came to my mind that you can use non-steroidal anti-inflammatory even before giving argon laser. And somebody said, I was outside or in the Western country at that time, they gave me this medication and this helped me. I didn't feel any pain. So I thought this is something which probably traditionally, wherever we are trained, we never used to do that cycle, but that tells you that if you give a painkiller before the pain is going to be induced, probably it helps, and definitely it gives you that added advantage that using preoperatively, it is going to stop that cascade which is going to occur. And the second thing which is important is if somebody gets inflammation in the eye, the one thing which this drug does is used once a day, and the important thing is it is guar gum viscosity, small particle size, so it's got improved pharmacokinetics. But the important thing is this is one of the drugs that has got the capacity to go up to the retina. So not all of the drugs, steroids, which you put in the drops, they'll probably end up just in the anterior one-third of the vitreous. So this is one of the drugs which really goes back to the end of the eye, and that is going to reduce that inflammation which you want. And especially if the gum guar is the derivative which is used and which is extracted and acts as a stabilizer, emulsifier, and thickening agent, suspending the particles over there. So it's more comfortable to the patient when you give that patient, because we used to have diclofenac drops before, and I remember whenever that patient put those drops, it always used to hurt, because there's a psychology in that patient that the more the drop hurts, probably it works better of that. So some patient told me that give me jo katre jinse dard hoti hai taaki wo meri shayad aankh ke liye zyada behtar hai. But this reduces that thing, and the particle size, a third the found form is knee pack 4 over here. So what we want is we want a particle which goes behind, goes to the back of the eye, and reduces the chance of cystoid macular edema. Especially with the advent of phacoemulsification, all of us are very sort of eager to do cataract surgery, and sometimes it's difficult to stop somebody from getting cataract surgery. I get a lot of people that they say, everybody has said that you need to have cataract surgery immediately. I said, no, you've got an early cataract, you can live with it at that point as well. But if somebody does have a significant cataract, posterior subcapsular cataract, vision is probably 6/6, but the glare is significant, you can do cataract surgery. In the West, they do cataract surgery. But the major challenge is sort of cystoid macular edema, which can sort of give you a problem, because as I told, steroids, topical steroid might not reach the end, or they do not reach up to the end of the posterior segment compared to what it does. So the half-life is single ocular dose of Nevac 4 tissue concentrations have leveled, declining with half-lives ranging 5 hours in aqueous to 19 hours in the lens and retina. This is exactly what we want. Like, we know that the compliance in glaucoma medications, the patients who use glaucoma medications like travoprost or latanoprost, if you give them in a once a day preparation, it is much sort of compliance is much better compared to giving it to 3 drops. You're already giving them topical antibiotics and steroids initially as well. So upon entering the eye, it can mobilize by intraocular tissue, and it's converted into amphenicol, which you can see. This is the active particle over there. So it goes inside, and this is then it penetrates inside and acts over there. So then if you compare what is NEPAC and the difference between NEPAC 4, the concentration is, you can see, is 3 times higher, the reduced dosing, which I said. And then formulation enhancements which have been done includes gum guar and polyethylene glycol, which is a demulcent, and controls carboxymethyl methyl cellulose as well in those. And the pH has been made by NEPAC is 7.4, while this is 6.8, and approximately 40% smaller particle size, faster dissolution, Cmax and AUC and aqueous approximately 2-fold higher in these patients. So this is one of the things which indicated dosing, which we already said once is 3 a day, this is once a day. We've gone through this. So this is another study which shows that 18 patients of 18-year older and NEPAC 4 suspension versus dose QID, and then dose post-operatively, you can see at day 1 prior to surgery, and then 1 drop QID and 1 extra drop 120 minutes post prior to surgery, 1 drop QID for 14 days. The primary efficacy, reduced inflammation at 14 days. I think going through this one is probably written QID rather than OD in that one. So NEPOC, when you compare it with knee pack as such, which is 3 times a day, once a day, was superior to its vehicle at completing clearing of inflammation at day 14 post-operatively over there. And it resolves pain. So I think one important thing which we mentioned was reducing the inflammation, CME. The second is reducing the inflammation in the eye. So why is it important that you use it separately and not sort of independently? Why does not it replace steroids? Why do you have to use steroids? Well, that is a problem which we found with non-steroidal anti-inflammatory, that they have come up with anti-inflammatories which are better and better, but still I think the ultimate non-steroidal anti-inflammatory which is going to replace steroids. So you come, because steroids reduce the inflammation, but the challenge is they are going to produce increased intraocular pressure in patients who are sensitive to sort of rise or who are glaucoma, who have got sensitivity to steroids, so that they can get induction of glaucoma in these patients. So this is another study population. So knee pack force suspension dose, knee pack forward suspension, vehicle dosed QID. So it's a complete clearing of inflammation as percent of patients with the true zero cells and zero flare. So knee pack forward is 65%, and suspension vehicle once a day it's 32%. Knee pack suspensions 3 times a day 67. Knee pack suspension vehicle 3 times a day. So there's a different comparison of where you can reduce the inflammation, and then how much it 86% the pain is resolved in these patients. And along with that, that was patients who were getting cataract surgery. Then the other uses are patients who are going to have diabetes and they do get inflammation at the back of the eye. So does it actually play a role in diabetic macular edema? Probably it does, but probably it does not play that much of a role that anti-VEGFs play, or steroids, intraocular steroid, intravitreal steroids play. So there is probably a sort of a role, but a minor role for non-steroidal patients controlling diabetic macular edema in that patients. The other thing probably which I tend to use more is patients having pain in the eye. If you have just ocular pain, sometimes I tend to use it. It's probably more of a off-label use, but if you tend to use it, sometimes people feel that the pain is better. It reduces that minor pain you have, because we have a tendency that we tend to give mild steroid like fluoromethalone. So this is something which can be replaced for that thing, to see if the patient is some mild unexplained inflammation, probably it can help with that as well. So, in summary, its proven efficacy, established safety, and its decreased dosing. So, the inflammation is completely clear in about 2 to 3 patients at day 14. Ocular plane completely resolved at day 14, and daily post-operative once a day daily regimen. I think the third thing which it's used most commonly is after photorefractive keratectomy. The patients have a lot of pain, especially PRK. So it's very useful to use in those patients, and especially in these patients, you will get the compliance is better, the pain relief is better. Probably you put it at that time, it helps the patient resolve the pain at that time. So I think this is the summary of this is a wonderful drug which is helpful with the patient and which helps us resolve the complications which occur in these patients. And but you have to use it judiciously. Where it's needed, you need to use it at that point. Thank you very much. If there's any questions, I can answer those.
Thank you very much, Professor Muin. That was excellent talk. So conclusion is that we should use this NIPAC for at least 2 weeks post-operatively to reduce the chances of edema. I would request Professor Mazhar Ishaq Saab to please come on the stage and take the chair for the session. The next speaker is a renowned cornea specialist, Professor Bilal Faiz Khan. He is Dean of United Medical College. He has done his fellowship, trained in cornea and refractive surgery from US, and also the fellowship in keratoprosthesis from Harvard Medical School, USA. His talk is on the science behind dual polymer hydration in the dry eye management.
Assalamu alaikum, ladies and gentlemen. Thank you very much for the organizers for letting me come to this auspicious occasion to Lahore. We're going to talk about the science behind polymer tube-like hydration system. I am a corneal refractive surgeon. I have done my fellowships in cornea, refractive surgery, residency and my fellowships in keratoprosthesis from Harvard Medical School in Boston, and I'm currently working in Karachi. I'm a member of the American Academy of Ophthalmology, Boston Keratoprosthesis Group, and the Tear Film and Ocular Surface Society. There are over 7,000 PhDs plus and other people working on an ideal tear film and how to improve the corneal surface. Overall, in the world, the market for the ideal tear film is around 18 to 19 billion dollars. People are searching for the best ophthalmic solution for the eye. Most of us understand cornea as a subspecialty. We don't know people who started all of this. This is Professor Dr. Klaus Tolman. He was Swedish in origin, passed away last year. He started the subspecialty of cornea in the world. And he was the first person to make cornea as a subspecialty. He is called the father of the classical cornea. I was blessed that I was his first artificial cornea keratoprosthesis fellow for 2 years. Professor Tolman has produced over 300 trainees as professors at the moment. And we all talk about cornea, the medications, and dry eyes, and so on. And it's a big, big issue. This is Professor Eileen Gibson. She worked at the Scapin's Eye Research Institute in Boston. She was the expert on epithelial cell. She was an epithelial cell biologist. For those of you who use the indirect ophthalmoscope, Dr. Charles Scapins started to manufacture the actual indirect ophthalmoscope, and that is where Dr. Gibson worked. And the subspecialty of vitreoretina was started by Dr. Scapins at Boston at the Mass Eye Infirmary. So Dr. Eileen Gibson's interest was in the research on the mucins of the wet surface epithelium. We just assume that it's just a liquid that needs to be put into the eye, but there's a whole science behind it. There are different mucins. Her recent publication was on the monoclonal antibody to the cytoplasmic tail of MUC16. So they have gone from mucin-related antibody MUC1 to MUC16. And again, I had the privilege of working in my own artificial cornea lab, and if I had played my cards right, I would have done my PhD, but I did not play my cards right. So moving on to, I do not have any financial interest in the product under discussion, nor on the company. We will move forward. Dry eye. What is happening in the world? There are nearly 500 million people in the world who are complaining of dry eye issues. It's a big problem. We do not understand it if we don't have it. It is more prevalent amongst women as compared to men, and as age increases, the prevalence increases. And there is an expanding spectrum of the dry eye. We should understand there are traditional causes, surgical, and then environmental causes. We all understand the causes, age, environment. Most important thing is we are looking at dry eye, but we have to understand why do we have dry eye and what is the cause for the dry eye. It's not just the tears. It's inflammation, infection, autoimmune diseases, medications. All those things cause dry eyes. Another recent factor that we'll all experience is the use of the social media, where we are looking at our cell phones constantly. There are many studies and papers which prove that the blink rate actually goes down by around 50% when you're staring at a monitor. So, symptoms, you all understand: dryness, grittiness, scratchy eye, blurred vision, and a foreign body sensation, and it affects the quality of our daily lives. Driving, reading, computer work, watching, everything gets affected. As we understand, the components are the lipid, the aqueous, and then the mucin. And the mucin that I was talking to about, the monoclonal antibodies, MUC16, and so on. So there are physicians and scientists who are working to identify the exact mucins which adhere your actual tear film onto the surface of the epithelium and onto the cornea, whether it's conjunctival epithelium or tarsal epithelium or the cornea. So if you can make the ideal medication which can go and target the antigens attacking the mucin adhesions, you would have the perfect tear film. Moving forward, as we understand, I usually give the example of a wiper in a car. If you have just water in the wiper fluid, it dries off the moment the air hits it. If you put 2 drops of oil in the wiper fluid, it's going to form a layer. And if you put a little bit of mucin in it, and it is then going to form a permanent adhesion with the surface of the cornea. So it's very easy to explain to the patient as well कि आपको वो कहता है जी मेरी तो आंख में आंसू वैसे ही बह रहे हैं, आप कह रहे हैं तो ड्राइनेस है आपको, तो आप कह रहे हैं कि एक तरफ ड्राइनेस है और दूसरी तरफ आप कह रहे हैं आपको आंसू भी बह रहे हैं, तो मेरे तो आंसू बह रहे हैं, मेरे ड्राई तो नहीं है. तो इट्स वेरी इजी टू एक्सप्लेन अगर आप गाड़ी की विंडस्क्रीन वाइपर की कहानी उसको थोड़ा सा सुना दे तो. कहानियां बहुत सारी सुनानी पड़ती हैं, बट दैट्स वन ऑफ दोज. And again, as I mentioned, it is changes in the tear film, ocular surface disease, inflammatory cascades, and development of symptoms. Unless we treat the actual underlying disease, there is no perfect tear film. There's no perfect artificial tear. There's just none. So you have to treat the underlying disease. चाहे आप उसको orally cyclosporin दे रहे हो, methotrexate दे रहे हो, topical steroids दे रहे हो, limbal plugs लगा रहे हो, whatever you're doing, you have to treat the surface. Coming to the topic at hand is a hyaluronic acid. It's a naturally occurring compound. It is found in the vitreous body, synovial fluid in the skin. Has similar properties to the tears, increases viscosity, increases hydration and moisture retention. And it has been used in the dry eye industry forever. And like I said, it provides tear film stability, corneal wettability, epithelium healing, and so on. And it also increases the adhesion to the surface of the cornea. Now, the two-blink hydration that we're talking about is a product which has got a combination, as the name suggests, two different things are in there. There are the actual ingredients, active ingredients, and most of the artificial tears that you'll find are the polyethylene glycol and the propylene glycol. However, in the two-blink, you have a combination of HP GOR, sorbitol, and the sodium hyaluronate, amongst other things. And the preservative is a polyquad. What exactly is the two-blink? Is essentially the active ingredient polyethylene glycol and the propylene glycol. We have them in most of the tear films, artificial tears. The HP guar borate combination with the hyaluronic acid is increasing the retention of that particular liquid onto the surface of the cornea and the conjunctiva. It is, and it's sort of also, and we'll discuss later, it provides cellular protection and from desiccation, and increases the wettability and the lubrication. The idea is you have got two different modes by which you're increasing its sustainability. The in vivo studies of the combination show improvement in the damaged cells, and we have already talked about these single mechanical integrity, the surface revetting, duration increases, and the hydration and lubrication increases. There are two polymers, as we discussed, and it provides a superior surface wettability. And there is again, we will talk about that in the detail shortly. The in vitro cell model, there was a preclinical study which shows the effects of the hyaluronic acid and the guar artificial on the protection, recovery, and lubrication. The objective was to demonstrate the benefit of the new lubrication, the two-blink formulation. What it showed was that the desiccation, the corneal epithelial cells were treated with the new formulation. It shows cell hydration and surface retention as assessed using cell viability assays. Cell and cell barrier protection was seen. They were pre-treated and exposed to a surfactant detergent. I guess I need my glasses now. Sodium fluorescein was applied, trans-epithelial resistance was checked, and cell viability assays were assessed. Surface lubrication was assessed, and the pericardium tissue was treated with test formulations. Basically, the more friction you have, the more damage that you're producing and the more friction you create. What the study found was that there was increased cell hydration protection with the combination product than with the alone single product, the hyaluronic acid product. There was increased cell hydration by 260% when you use the combined product. At the same time, the moisture retention was around 400% more when you have the combination of the two-blink hydration. That means the guar and the hyaluronic acid helped. It also showed that the improved cell viability This is the electron microscope. Three things that you see, where there was only the vehicle was used, the hyaluronic acid, and then when you had the combination with the guar, the epithelial cell viability was more when the combination product was used on the electron microscope. And again, this chart shows that the friction coefficient was lower in the combination as compared to the vehicle. The overall, what it shows is that the two-blink hydration allows ocular surface restoration of damaged cells as well, as has been shown by the electron microscope. Another study, which was the Ogundil in vivo study, which compared the two-blink, which was the HPG and the hyaluronic acid, with 5 other products which just contained the hyaluronic acid containing tier products. And again, it was a randomized mass in vivo study which showed that the corneal injury was done using fluorescein staining and imaging was done. After 24 hours, the cornea was stained with fluorescein and re-imaged. And the key endpoint was reepithelialization, debridement states, and the reepithelialization rate. What it showed was that amongst all the products that were tested, there were 5 products tested against the two-blink. It shows that the percentage of fluorescein negative corneas 24 hours after debridement was highest in the two-blink product. At the same time, the average area and the percent area of reepithelialization, as you can see from this lower end, as I think 98%, was reepithelized after 24 hours when you had the combination product with the guar in it. And the average reepithelialization area of the wound was faster. The rate of healing was also faster in the Ogundil study. And at the same time, I'll move forward with this. So overall, what we're trying to say is that the combination, first of all, you have to understand what dryness is. And if you have dryness, you have to treat the underlying disease. And once you've understood the underlying disease and you're managing that, the two-blink combination with the HP, guam, and the hyaluronic acid is far superior in improving the wettability, the retention, that means kitni der tak wo wahan ruka rehta hai, and also the re-healing of the epithelial defects. And whenever you are operating, you do have wounds all over, and it has been shown by multiple studies that the wound healing has also improved. I'll give you my experience, a recent experience, and those of you who are on the OSP WhatsApp group who have already seen this. This is a young kid with a limbal dermoid, which was actually a corneal dermoid, and I had the opportunity of seeing him. He's anophthalmic in the other eye, and we operated on him. And subsequently, I put in a Boston keratosis type 1 in his eye, and since he's a child, putting medications in his eye and discomfort was a very big issue for us. And I do not believe in giving patients Alkane at all, whether it's diluted or not, because long-term use or even mild use of Alkane itself causes dryness, and it also causes and it's epitheliotoxic. It actually causes corneal melting if you use it for a long period of time. And I don't believe in it per se. I would rather give you oral medications rather than that. And this particular child, post-operatively, I think about 3-4 weeks was like this. And you can see that and his vision is actually ambulatory at the moment. We're trying to improve his visual ambulation with surgery, with refraction. And this child, I have used the two-blink combination aggressively on him every 1 hour. His mother did it every 1 hour, so that we could ameliorate the pain and the discomfort of the surgery that had caused him. So all in all, it is an interesting and a good product with the combination. And in the end, I always like to say thank you. Long live Pakistan. If you have any questions, I'm more than happy to answer them. Yes, ma'am. At what pH is it most active? Acha. Madam, it is active at the pH, as far as my understanding of the literature is concerned, it is active between 6.8 to 7.4. Okay. That's my understanding.
Right. In a dry eye, do you know how much the pH is?
Madam, the pH can be either depending whether it is what type of dry eye are you talking about?
Any dry eye where the tear film is, it's hypersatonic, it is scanty, so the pH goes way down. So the polyguar, it cannot work because the pH is around 6, 6.4 or even lesser.
Madam, like I told you, if the eye is completely dry
Yes.
and the pH is, let's assume 6.1, none of the artificial tears are supposed to work at that pH.
It's
None
not
of them.
true. The mechanism of this polyguar is it makes it as soon as the eye drop goes in the eye, when the pH is 7 or 7.2 alkaline pH, it forms a gel that protects the cornea. But in an already dry eye, the pH is way below, and polyguar cannot work. Another problem with this product is that the preservative in it is polyquad.
Yes.
Polyquad is the next worst preservative to back. And there are other preservatives which are less toxic.
Fair enough. I would have rather preferred a no preservative product.
Absolutely. But even polyquad is a bad preservative.
I would not know that. I did not know that.
It is.
Fair enough. And as far as completely dry eyes are concerned, I would have, like I suggested, that we have to treat the underlying disease.
Yes.
Just artificial tears are not going to do anything to them.
So
No matter
the
what.
last question, what is this ocular residence time? How long does it stay?
I do not know that. I do not know what the ocular residence time is. I do not.
Okay.
I'm not the pharmacological expert on it. I'm just used it.
All right. Okay. Thanks.
Anything else? Okay, thank you.
Thank you. I would request Dr. Bilal, please take the chair on the stage, please. Thank you very much, Dr. Bilal. This was a very nice presentation, and questions and answers are the beauty of any discussion at any forum. This next presenter is Dr. Irfan Qayyum. He is Associate Professor of Head of Ophthalmology Department at Gujranwala Medical College. The introduction I was given to him for him, there are a lot of fellowships. सब नहीं पढ़ सकता यार. तो आप आ जाएं बस. The topic is the role of olopatadine 0.7% real case scenarios in allergic conjunctivitis.
Sir, thank you very much for giving me the honor. I'm Dr. Irfan Qayyum, working as Associate Professor and Head of Ophthalmology Department in Gujranwala Medical College. Today we will talk about olopatadine 0.7% in allergic conjunctivitis. This is a beautiful building of Gujranwala Medical College where I work. So, ocular allergies affect 6 to 30% of the general population. The most common presenting symptoms are red and itchy eyes, followed by burning, stinging sensation, swelling, and sometimes tearing. IgE, immunoglobulin specific for that allergen, is produced. This IgE binds to FcR1 receptors, which is a part of the mast cell of the conjunctiva. And this produces inflammatory mediators resulting in increased vascular permeability that results in immediate itching and redness. This is a treatment which we give in routine. Sometimes we give artificial tears, anti-allergics, alpha agonists, sometimes NSAIDs, sometimes mild steroids, and sometimes immune modulators. But today we will talk about olopatadine, which has got dual function. So olopatadine is an antihistamine and mast cell stabilizer that is commonly used to treat allergic conjunctivitis. Olopatadine 0.1% was launched in 96 and 0.2% was launched in 2004, and then 0.7% was launched in Pakistan in 2024. High concentration solution of olopatadine provides significantly improved reduction of late phase ocular allergic conjunctivitis symptoms in addition to relief from early phase symptoms. High concentration of olopatadine also provides significantly improved reduction of redness in the early phase. Improved relief from these early and late phase symptoms can be achieved through once-a-day dosing of relatively high concentration olopatadine solution as opposed to greater dosing frequencies. So we will discuss our first case. A 12 years old boy, resident of Daska, brought to us in OPD by his parents with history of severe itching, photophobia, stinging mucus discharge for the last 2 years. He was now complaining of progressive blurring of vision associated with headache and severe eye pain from the last 3 to 4 months. For the last 2 years, he has been managed at a local clinic with topical steroids and which was betnisol. The family admits to unsupervised steroid use. On examination, he had cobblestone papillae, visual acuity in right eye was 636, while in left eye was 624, and intraocular pressure in right eye was 30 and left eye 26 millimeter of mercury. On fundal examination, he had bilateral increased cup to disc ratio. Patient was given full anti-glaucoma therapy along with topical olopatadine, which was GPAT OD 0.7%. With full anti-glaucoma therapy, IOP intraocular pressure came down to 13 millimeter and 12 millimeter in the left eye. As it was a steroid-induced glaucoma, so intraocular pressure lowering drugs were initially tapered and then stopped. OD dose of olopatadine 0.7 was continued with good compliance now. If we compare 1%, 0.2 and 0.7%, then 0.7 olopatadine, it works in minutes and it provides all day and night cover. Typically, the 0.7 formulation requires only once daily administration, making it more convenient for the patient to incorporate into their routines. This ease of use not only improves adherence to the treatment plan, but also contributes to better overall outcome in managing allergic conjunctivitis. Moreover, the improved compliance helps reduce the likelihood of missed doses. This leads to more consistent symptoms control and better long-term management of the condition. Now the second case, a 10 years old boy, resident of Gujranwala, presented to us in ophthalmology clinic with complaint of severe itching, redness, watering for the last 2 years. For the past years, he has been prescribed multiple antihistamine eye drops on and off, which the child has been using excessively because he felt temporary relief. His mother reports that he has become irritable and resistant to use of drops due to stinging sensation that he feels after the drops. On examination, the upper tarsal conjunctiva reveals cobblestone giant papillae with mild limbal edema and occasional Trantas dots. The medication was reviewed. We started with mild steroid and olopatadine, GPAT OD 0.7% eye drops. Then the steroids were tapered and 0.7% olopatadine was continued. Now the compliance is very good because of OD dose. This olopatadine 0.7 eye drops are associated with reduced preservative toxicity. Once daily dosing minimizes overall exposure of ocular surface to back. Lesser irritation of the conjunctiva, lesser destabilization of the tear film, lesser potential damage to corneal epithelium over time, and lower cumulative preservative load compared to multi-dose regimen. Now there is another case of 9 years old boy, resident of Kila Didar Singh, presented in our ophthalmology clinic with complaint of severe itching, watering and redness of both eyes for the past several days. Over the past years, he has been using multiple eye drops on and off, including over-the-counter antihistamines and lubricants, based on advice from different local clinics. His parents report inconsistent use of these drops. 6 weeks ago, due to severe exacerbation, he was taken to local practitioner who administered him supratarsal triamcinolone acetonide injection after which his symptoms temporarily resolved for a few weeks. However, now his symptoms have returned with greater intensity, and for the past 5 days he has intense itching. He was advised olopatadine 0.7% in OD dose, and patient reported back us after 1 month with much improved compliance and more relief. So in conclusion, we can say that olopatadine 0.7% demonstrates superior efficacy compared to 0.2 and 0.1 formulation in terms of faster symptom relief, longer duration of action, better compliance, lesser preservative related side effects, and overall better therapeutic outcomes. These advantages make olopatadine 0.7% the preferred treatment for managing allergic conjunctivitis, offering patients a more effective solution for the symptom control. Thank you very much.
Thank you, Irfan. I think olopatadine पे से अच्छी presentation नहीं हो सकती थी. The next speaker is Dr. Mohammad Hamza. He is consultant ophthalmologist at Liaquat National Hospital, Shahzad Eye Hospital, and Retina and Eye Care Center. He is also ex-consultant at King's College Hospital, London, and faculty of Royal College of London. His topic is the allergy, dry eye, keratoconus triad, a single spectrum of ocular surface dysfunction.
Assalamu alaikum, and thank you very much for the introduction. I'm also assistant professor at UMDC as well. Okay, so lots of good presentation, and you've been having lots of information in one single session. It's not easy to retain all, but if you get away with one single point, I think that would be the success of this symposium, and this is what we are here for. And what I'm going to talk about is not something which is commonly think about, is basically the allergy, the dry eye, and then the keratoconus. The people who run the anterior segment clinics, they probably know about more the keratoconus than people run the vitreoretinal services or the glaucoma services. So the overview is basically like it's an ecosystem. Okay, it's interplay of allergy, dry eye, and then the keratoconus, and it's a shared inflammation process. And the clinical and the surgical implication also resides on it, what they share too. Give you an idea what is like an ocular system. It's a tear film has a 3 component, okay? Lipid, aqueous, and mucin. And every layer or each layer has their own function, and every layer has to be treated by a particular drop. You can't give the lipid containing drop in the aqueous tear deficiency. Similarly, if you have aqueous tear deficiency patient or autoimmune related patient, you can't just give the lipid high viscosity drop and then think about that the dryness will get better. It's not going to get better, okay? Because it's not the process, it's the inflammation which you need to treat, because the dry eye disease is an inflammatory process, not just the dry eye because of the fan is turned on or it's an environmental factor. The common factors which are the rise in the dry eye are the digital screen use, which we all are aware of, not to mention aging population. The older the age, the more the dry eye, because they blink less, the goblet cells reduce, the mucin component gets reduced, and the aqueous tear deficiency, they get the arthritis by the age of 60 or 60 plus. So because of that, you get the aqueous component playing up the role as well. And then nowadays, the post-refractive patient, LASIK, femto-LASIK, SMILE, whichever the PRK, whichever the laser surgery you do, you get this. The global prevalence, if we talk about, it's everywhere. It's not only in our region, like in Pakistan, it's everywhere, and it's quite prevalent. It's about 20-30%, something like that, of all population, which is a big chunk. So what it is, the dry eye increases the corneal nerve hypersensitivity. If you've seen the patient in your clinic, they must have called you and say, we cannot open the eyes in the light, or the fan actually disturbs them. Is basically because they have got the increased sensitivity of the corneal nerves. This is why there's a first symptom you think about, oh, actually this may be this, and then the hyperosmolarity plays another role, which instabilize the tear film, and then they rub in the end, and which obviously increases the risk of the corneal denaturation, which means that the corneal shape can get changed. So if we just summarize these 3 things, the hyperosmolarity basically causes the ocular surface damage, which is the first step, and then comes the inflammation, which is the ocular surface damage, and then comes the epithelial damage, which involves the cell loss, apoptosis, goblet cell loss, mucin cell loss, and hence leading to the dry eye disease. So basically it's a triad, okay? And these conditions frequently coexist, which, as I say, which sometimes we don't see well, maybe the pressure or fatigue, or maybe sometimes we just don't pay attention to those things. So mechanical rubbing amplifies the disease progression in the keratoconus especially. This is well proven everywhere. So what does the allergy does in this thing? We've talked about the dry eye. Now, the second component of this triad is the allergy. And what does it do? It basically releases the histamine, and especially the IL-4 and IL-13, which causes the eosinophil rise, and then the chronic inflammation. Patients, that's like, ek din theek hai, dusre din kharab hai, teesre din theek hai, 4 din kharab hai. So this whole just keep going on. The cycle repeats itself, and then the persistent itch causes the chronic redness, and the chronic rubbing, later on the mechanical trauma, which can lead to the shape change, which leads to the keratoconus. So this is how we are here to discuss this thing. It's not only the dry eye, it's basically dry eye, allergy, and then the keratoconus link. And frequent or constant rubbing, be it from the dry eye or the allergy component, is basically releases the production of IL-6 or MMP9, which causes the stromal degeneration, which is the hallmark of the keratoconus, isn't it? So what we need to think about is not only treating the dryness, we're treating the allergy, okay? And then we are reducing the chances of patient for the shape change or the corneal surface changes. And again, what I'm trying to emphasize here is when you see the patient in your clinic, and if you think, oh, it's just a dry eye, take this drop. It's not only the dry eye. You have to eliminate the allergy component as well, because until you eliminate the allergy component, you can't win from the dry eye alone. Because by the time patients been rubbing and coming to your clinic, they have already got the increases on the cells, and there is already a chronic inflammation. So chronic inflammation, epithelial barrier compromise, neural dysfunction, and then the biomechanical weakening, which leads to keratoconus. And just like the people who are not aware of keratoconus, for me saying again and again and again, keratoconus is basically ectatic disorder of the cornea. And it's mostly central or paracentral. They get the thinning, shape change, and patient's cylinder number gets increased. Astigmatism basically comes in, and which sometimes cannot be corrected with the glasses. They get the contact lenses. If not, or intolerant to, then they go for the surgical options. It is considerably higher in Middle East, Pakistan, India, China, and Australia. Australia, they say, I think 1 in 70 patient has a keratoconus. So this is very high prevalence in the Australia. So this is a clear example of if the patients keep rubbing. Do we have a pointer? Anyway, you can see there's an inferior steepening of the patient and a classic. I mean, there's not much Kmax higher. There's not much posterior elevation. It's basically the anterior problem, which basically causes the corneal surface change. So, eye rubbing in allergic eczema patient. Sometimes we don't ask the patient if they are suffering from any skin disease, which is very important. We should. Some of the, especially the younger kids, they might have eczema, or they might have got psoriasis, or they might have got someone in the family which might have as eczema and they have acquired it, things. So this again increases the allergy component. This again increases the rubbing factor. And then the VKC patients, especially the kids, they keep rubbing. So you have to treat it. And then if you don't tell them, there's a higher risk of 65 to 70%. If they keep rubbing it, it can lead to keratoconus. It's not me saying, it's the data published which is saying the number one cause of the keratoconus progression is the eye rubbing. Even after the CXL, if you keep rubbing it, it's going to progress. So even the CXL cannot stop it. So we have to basically consider the basically biomechanical weakness, the mechanical trauma, and the stromal injury. And then these little things can change and can lead to the keratocytes, decreasing the keratocytes or keratocytes apoptosis, which causes the stromal thinning and hence leading to the increased release of the IL-6. Now, these are just the numbers for someone, but for a person who has had the keratoconus or who is going to have the keratoconus, it's a life-changing. And this is why we say often, we have all seen biryani, we love biryani, isn't it? But what is unseen is often the most important, which is the calories in the biryani. Nobody talked about how much calories in the biryani. I've never ever seen anyone asking the calories in the biryani, but they always ask the calories in the chicken sandwich or salad or whatever. So the preventive strategy is to treat the allergy. Okay, treat the dryness aggressively. You have to stop the release of the mast cell. You have to stop the release of histamine. And then the triggers are dryness, screen fatigue. Then teach the patient, okay? Tell them what it is, tell them how you can get better, and then emphasize. If not, then you do the CXL. If you think they're not going to stop it, do the CXL if it's a chronic or mechanical rubbing. So my personal strategy, this is my own experience, is I always in the dryness patient, I give the treatment of allergy as well. Okay, for meibomian gland dysfunction or preservative-free drops, this is my baseline. Olopatadine, Dr. Irfan Qayyum has already talked about 0.7%, works really well. I mean, I'm so happy being a corneal surgeon. If I have got a drop which is 0.7, just need to put once a day at bedtime especially, People are loving it. And I've got hundreds of patients on the olopatadine. There's a new tube, which is a bedtime again. Because the release of the histamine would be at night time, so you need to prevent something which also blocks the interleukin release as well at bedtime. And for that, you need an ointment. Okay, no, drop's not going to work. Drop going to work at the daytime, but at that point, you will not have the interleukin release either. So you need something for the night time, and that would be the Optolube. I mean, we have the Optolubes. I'm saying Optolube, but there's something to take care of your dryness. And then if it's not going to work, then you have a keratoconus full blown. You do the CXL, scleral contact lens, KS-DOC, PK, whichever. So the conclusion is, if you have a patient of dry eye, think about allergy. If you have a patient of allergy, think about dryness, because these two coexist. And if you don't treat both of them, some of the patient can actually go and have the keratoconus later on, which neither of you want. Thank you very much.
Thank you very much, Hamza. Hamza is very right. जितने लोगों का keratoconus होता है, उसमें बड़ा मसला ये है कि we have the patient with the complaint of either itching or burning sensation in the eye, and there is a very thin line between the diagnosis of these two. और आपको कई दफ़ा दोनों देनी पड़ती हैं. So we have a panel here for any question, if you have any query. और at the end of the summary is कि जब किसी patient को आपने keratoconus के साथ देखना है, तो आपने उसको एक lubricant भी देना है tube link की फॉर्म में, और आपने साथ उसको एक एंटी एलर्जिक देनी है Z-Pad OD की फॉर्म में, और कभी आपको फ्यूचर में उसका मोती ऑपरेट करना पड़ जाए तो नी पैक फोर्ट भी देनी है. दिस इज द एंड ऑफ द सेशन. थैंक यू वेरी मच.